We recently discussed why microscopic colitis causes diarrhea and how GI doctors evaluate and diagnose the condition. In this video, let's discuss how GI doctors treat microscopic colitis. If you're found to have microscopic colitis, you're almost certainly going to want to start a new medication. If you have relatively mild symptoms, then Imodium, an over-the-counter medication, may be enough to slow down your diarrhea. But more likely, you've gone through having a colonoscopy because you had really severe symptoms, and you're going to want to start a new medication, and the one that I most commonly recommend is budesonide. It's a steroid, and so it's going to be potent for controlling the inflammatory component that drives microscopic colitis. But the beautiful thing about budesonide is that upon absorption, the liver rapidly breaks it down, and so it has very few of the systemic side effects that we typically think of being problematic with long-term steroid use. We're going to initiate budesonide at a high dose that will often give patients relief within days, if not weeks, but we need to continue the medication for a full 2 months at that strong dose to get good control of the inflammation to ensure that it's really gone. Thereafter, we can taper the medication down over a final month over a couple of steps, and that gives you a full course of 3 months of therapy with budesonide. Along the way, it's important to look back to see if any of the medications that you take may be triggers of microscopic colitis. We discussed those triggers in our prior video, but as a quick recap, they include medications that are commonly prescribed for managing cholesterol, for mood disorders, and medications that I typically prescribe to suppress acid production. Some of those are very easy to change. For example, cholesterol medicines are often very interchangeable, and their benefits are found over a long course of time. And so this is one that I often encourage that the patient go back to their primary care doctor to see if they can make a substitution. On the other hand, it can be much more difficult to try to change a medication that's used for a mood disorder, though working with a psychiatrist, you can taper one down and introduce a new one if we feel strongly that this may be what's driving your microscopic colitis and you're otherwise not responding to budesonide. We can also look if you're taking too much in the way of NSAIDs, because this is a medication that very often irritates the GI tract. Finally, if you're using tobacco, this is an important time to try to quit because this could be the trigger of your microscopic colitis. If you've taken budesonide and made appropriate changes to your medication, enjoyed generally really good relief of your microscopic colitis, but you have a few remaining symptoms, we can usually clean those up by using Imodium, cholestyramine, or bismuth. And then I think you'll enjoy very good control of your microscopic colitis. But what if you haven't really had any response to budesonide and you've made as many changes as you can to your medications, yet you're still in a really tough spot? How can we intensify your therapy to start to give you relief from this condition? Microscopic colitis is an inflammatory condition of the colon, and so it should be of no surprise that the same medications that we use for ulcerative colitis can very often deliver benefit for people who have severe cases of microscopic colitis. My next step is to go to a medication called azathioprine, and it stops the proliferation of white blood cells that are driving the inflammatory response of microscopic colitis. If that doesn't work, then we can move onward to infliximab or Remicade, an IV infusion that blocks the cell signals that tell the immune system to ramp up. And finally, if we're still stuck, then we can go to vedolizumab. And this is a medication that stops the trafficking of white blood cells into the colon. With these medications, we can very often get good control of microscopic colitis. But in the worst case scenario, if you're still having persistent diarrhea, we may need to turn to surgeons for help to actually remove the colon. This is a very rare need because most often we can get good control of the condition with medications alone. While microscopic colitis will very often respond to budesonide at the outset, it may return and require an additional course of budesonide in the future. At times, it will require an entire 6 months or even a year of intensive budesonide dosing. Because of that, we do have to start to worry about the ill effects of steroids, and so these patients need to be considered for bone scans, vitamin D levels, and their sugars need to be monitored. But again, because budesonide is broken down by the liver so quickly, those side effects are seen much less commonly than they would be if you were taking high dose of systemic steroids like prednisone. And more good news, microscopic colitis is not thought to increase the risk for colon cancer like ulcerative colitis does. And so there's not a future where you need to have intensive colonoscopies to monitor for risk of dysplasia. I hope that you found this information helpful for treating your microscopic colitis. Thank you for watching and be safe.